Hello coders, so we're picking up. This is Cardiology Surgery Part 2. We are starting on page 228 in your code book, and we are talking about endovascular repairs of abdominal aorta and or iliac artery. So again, as I was setting in the CPT-1 surgery, we are trying to do as many surgeries as possible through the smallest incisions. So again, for these, we're going directly into an artery to do a repair. Remember, endovascular, pertaining to within the vessel. Okay, now again, we have to remember the aorta. We've got the thoracic aorta. We've also have the abdominal aorta. And again, I always think of the aorta as a candy cane, right? Because it comes up over the heart and then comes down behind the heart like a candy cane, goes through the thoracic cavity, through the abdominal cavity, and then right around the belly button area. That's when it starts to separate out into the iliac arteries, going down towards the hips. Remember, iliac, I-L-I, is the hips. Remember, ileum, I-L-E-U-M, is talking about part of the small intestine. So spelling counts always. So these codes, 34701, 2, 3, 4, and 5, describe the introduction, positioning, and deployment of an endograft for treatment of abdominal aortic pathology with or without rupture, such as an aneurysm, pseudoaneurysm, dissection, penetrating ulcer, traumatic disruption, or the infrarenal abdominal artery with or without extension into the iliac arteries. So that's what's included. So again, when we're doing something into the vessels, getting to the vessel, which is the introduction, remember introduction, introducing something to the body, positioning, moving that catheter where it needs to go so they can perform the procedure. Deployment of the endograft. So again, these, when we talk about catheters, we talk about doing this type of surgery, these catheters are hollow, and they're hollow, so not only can we stick instrumentation into them, but we can stick things like the endograft through them. And what's really neat is for a lot of these procedures, when we're using stents, or in this case, when we're using an endograft, a lot of them, what they do is they use origami to make it as small as possible to get it through the catheter and then to deploy it or to open it in the vessel where it needs to go. So it's kind of a really neat thing. In the early 2000s, a lot of surgeons actually met with some of the world's best origami artists to find out the best way to compress these stents. Again, we're trying to do things as small as possible. We don't want to slice and dice if we don't have to, okay? Now, excuse me, the terms endovascular graft, endoprostheses, endograft, and stent graft refer to a covered stent. Okay, so stents most of the time are going to be made out of metal, and it's kind of like a spring. So it's very, very tiny, and then when they get it into the vessel, they open it and they deploy it, okay? Now, stents are used to hold a vessel open, okay, because of fatty plaque, because of a hardening, because of a narrowing, okay? However, these are a little different. These are covered stents, okay? So there's a picture of it. Hold on, it's in, I saw it last night. It's in your book of what the endograft looks like, and I will find it as we're talking. So just to give you an idea, a regular stent, if you go to page, oh no, there it is, perfect. So if you want to find a regular stent, you're going to see it on page 217 in your CPT book. And you'll see it's the stenting of the ductus arteriosus. It's code 33621, called initial hybrid palation. Okay, and you can see there, it's a metal stent and there's spaces. But if you look on page 220, we have a picture that goes with code 33864, which is the aortic root remodeling, okay, that we were talking about in the last video. And so you can see here, this is a covered graft, okay? So this is something that, again, the graft is inside and this is covered. Why is it covered? Because we're using these to deal with things like aneurysms and pseudoaneurysms. Aneurysm is a general bulging of a vessel, and the bigger the vessel, the more concerning the bulging is, especially in the aorta. Because what happens is if that bulging gets so big, eventually the walls of the aorta actually wear out, and then the patient can actually have an aortic burst where the blood then starts pooling in their abdominal cavity, and it's usually fatal. So when we see an aneurysm, which is the bulging, a lot of times we're going to do a covered graft or covered stent, I'm sorry. And the reason why is because we want the blood just to flow through the area it's supposed to. So a lot of times what we do is we allow the stent to kind of take place. So I'm going to bring up my paint here. I'm going to draw a little picture of kind of what this is going to look like inside the body with an aneurysm. While I'm doing that, a pseudoaneurysm is just a little bulge or a little pocket on only one side. So we want to kind of keep that in mind. So I'll draw the differences for you. Okay, so let's see, we got the pencil here. Okay, so I'm going to do red because it's an artery. So an aneurysm is when the vessel comes down and then there's this bulge, okay, and usually it's bulging on both sides. So what we do is we take a covered stent and we stent this area. So all of this over here, which I'm going to color in blue, all of this, no blood flow ends up going through there. The blood is going to flow through the stent only, okay? So that's an aneurysm, it's a bulge. So the stent keeps the blood flowing. And again, I didn't do it perfectly, but this would fit perfectly in there so the blood would not be able to get past it. Now, a pseudoaneurysm is a little different. It's when there is just like a pouch hanging off one side. And a pseudoaneurysm can be just as dangerous because if this bursts, again, we have a blood pool in the abdominal cavity. So again, we can put a stent in that will basically stent off the area and allow the blood flow to continue. So again, we have to remember that sometimes we might have to do what we call a bifurcated system. And that's because the aorta splits off into the iliac arteries, okay? So that branch can mean that we need to do a bifurcation. So let me go back here. I want to pull up this paint. Okay, so sometimes what we have to do is, if let's say we have an issue with where the iliac arteries are, and we have a bulge, right? So what they can do is they can make a stent that's what we call bifurcated. Because remember, bi means two. So the stent would go in, it would go in here, and then in here, and then the stent would go in this vessel as well, and still cut off the aneurysm. So that's the bifurcated, because it's going in two different directions. So when we see things, like in the next set of guidelines, the infrarenal aortic endograft may be an aortic tube device, a bifurcated unibody device, a modular bifurcated docking system with docking limbs, or an aorto-uni-iliac device. And again, it's going to depend on what's the problem with the aorta and with the actual iliac arteries as well. So it goes on to tell us the codes 34707 and 34708 describe the introduction, positioning, and deployment of an ilio-iliac endograft for treatment of isolated arterial pathology with or without rupture, such as aneurysm, pseudoaneurysm, arterious venous malformation, or trauma involving the iliac artery. So those are the other two reasons for these procedures, okay, the main reasons. So the first two are for people that have aneurysms and pseudoaneurysms. However, people that have what we call arteriovenous malformations. So what's supposed to happen in utero is that we're supposed to get chemical signals to different parts of our body to say, grow this, grow that, put this here, put that there. But again, chemical signals can be sent to the wrong places. So sometimes people have an abnormal artery or vein. It's bigger, it's smaller, maybe it has an extra piece that we weren't expecting. And again, sometimes arterial venous malformations can actually block the availability of the blood to flow through the body correctly. So we can fix those. And usually those are congenital, meaning the person's born with it. However, If it's something relatively small that is an arteriovenous malformation, it might not get found or caught until much, much later in life. It's still congenital if the doctor confirms they were born with it. The other is trauma. And again, think penetrating trauma. So, someone falls and gets a huge laceration. What's happening to those arteries? Those are major arteries that feed the abdominal cavity and the legs. So again, we're going to be very, very careful. We also, as it goes on, for treatment of atherosclerotic occlusive disease in the iliac artery with covered stents, 37221, 37222. So atherosclerotic disease is the other reason. Again, the atherosclerotic athero is fatty plaque. So this is the fatty plaque buildup that tends to come from excess fats in the body, usually cholesterol. However, here's what's interesting and you have to keep in mind. Eating cholesterol does not necessarily mean you have a problem with cholesterol, because cholesterol is found in our meat products, okay, and meat byproducts, eggs, cheese, milk, okay. But there are people who have a genetic predisposition because of family members to have issues with having high cholesterol. There are people who are completely vegan, who eat absolutely no animal byproducts that have issues with their cholesterol because they might have a genetic link in their family. So just keep that in mind. Occlusive disease does not always mean that their cholesterol is by their diet. It also could mean a variety of other circumstances. For instance, a lot of people have been talking about the keto diet. That's been the new thing recently. The keto diet was originally started for children that had severe seizures. And what the keto diet does is it changes the ketones in the body. And when it does that, the seizures lessen or sometimes completely go away. But it's a very high fat diet. But again, sometimes the end justifies the means. A lot of those kids, because they're starting it so early, sometimes at the age of 3 or 5, what happens is by the time they're a teenager and in their early 20s, they do have high cholesterol because they're eating heavy cream and eggs and bacon and all these very fatty foods. Now, they need to eat that so that they can keep their seizures away. But again, we have to kind of keep in mind reasons for these procedures. That's the other side of coding, the diagnoses, but always keep those in mind. Why would we do these procedures? So they also tell us here, for a decompressive laparotomy for abdominal compartment syndrome after a ruptured abdominal aortic or iliac artery aneurysm repair may be separately reported with 49000 in addition to 34702, 4, 6, and 8. So the decompressive laparotomy is, again, we're making an incision in the abdominal cavity to be able to make sure that we can properly fix the problems within the iliac and or aorta. Now, a lot of the next guidelines are going on. We're going to read most of them. This is something that, again, I'm going to let you decide what you would like to highlight here because this is all new information and whatever's going to help you is what you should go with. So, it tells us the treatment zone for endograft procedures is defined by those vessels that contain an endograft, main body, doculimbs, and or extension deployed during that operative session, okay? Adjunctive procedures outside the treatment zone may be separately reported, like an angioplasty, endovascular stent placement, or embolism. So again, these procedures are just for going in and deploying the stent where the stent's supposed to be. If we do something else, then we can code it in addition to. So it goes on to tell us, there's some examples. For example, when an endograft terminates in the common iliac artery, an additional treatment performed in the external and or internal iliac artery may be separately reportable. So again, what's included, what's not included. So this is a lot of what you can separately report for. It then goes more specifically into the code. So again, any catheterization or treatment of the internal iliac artery, such as embolism, may be separately reported. For 34701, 34702, the abdominal aortic treatment zone is defined as the infrarenal aorta. For 34703 and 34704, the abdominal aortic treatment zone is typically defined as the infrarenal aorta and ipsilateral common iliac artery. So again, they're giving us the specific areas of both the aorta and the iliac arteries that we can code for. So again, we need to make sure that we know what we're talking about. Now, the next set of guidelines tells us that 34702, 4, 6, and 8 are reported when the endovascular repair is performed on a ruptured aneurysm in the aorta or iliac arteries. Rupture is defined as clinical and or radiographic evidence of acute hemorrhage for purposes of reporting these codes. A chronic contained rupture is considered a pseudoaneurysm, and endovascular treatments of a chronic contained rupture is reported with 34701, 3, 5, and 7. So if this is a pseudoaneurysm, we're going to use the odd numbers. If this is an acute condition, so this is like an abdominal aortic aneurysm, a AAA, which is the most common condition that we see with the abdominal aorta, then we use the even numbers. Then we have code 34709 to report for placement of an extension prosthesis that terminates or ends either in the internal iliac, external iliac, or common femoral arteries in the abdominal aorta proximal to the renal arteries. So again, this is closer to the renal arteries. The renal arteries are one of the first major branches off the descending aorta, and those again go to the kidneys. As we continue on, it tells us 34710 and 34711 are reported for delayed placement of a distal or proximal extension prosthesis for endovascular repair for infrarenal abdominal aortic or iliac aneurysm, false aneurysm, dissection, endoleak, or endograft migration. So again, these are for when we delay the placement, maybe because we have to do a surgery prior to placement, or if something has fallen out of place. So like there's a leak or the migration, which is the movement of the graft. The graft itself is moved. We need to put it back in place. Now, pre-procedure sizing and device selection, all non-selective catheterizations, all associated radiological supervision, interpretation, and treatment zones for angioplasty and stenting when performed are included in these codes. So non-selective catheterization is when we go into a vessel and we look around. So we're not going into branches, we're just looking around, okay? However, non-selective catheterization is not included in the following codes: 34701, 2, 3, 4, 5, 6, 7, and 8. This is all included, okay, in these codes. So again, we're going in and we're looking around at the vessel. However, it tells us selective catheterization of the hypogastric arteries, renal arteries, or arterial family outside the treatment zone of the endograft may be separately reported. So again, if we're going into another vessel, then we can report that. Or as it goes on to tell us, if we're doing an intravascular ultrasound, we can also go in and we can also code that as well. Goes on to tell us fluoroscopic guidance with radiologic supervision interpretation in conjunction with the endograft is not separately reported and includes all, just need to find my place again. Okay, there it is. And includes all intraprocedural imaging like angiography or rotational CT of the aorta and its branches prior to deployment of the endovascular graft. Again, it also includes fluoroscopic guidance and road mapping used to deliver the endograft and intraprocedural and completion of an angiography to confirm position, detect endoleak, or evaluate runoff. So again, the fluoroscopy and the angiography all inclusive in these codes, because after we put the stent in, we want to make sure it's working properly. So we do radiology to make sure that it is. Now codes 34709, 10, and 11 also include non-selective introduction of guide wires and catheters into the treatment zone for peripheral arteries, and then it goes on again. If it's selective catheterization, it can be reported separately. Now, these codes also include balloon angioplasty and or stenting within the treatment zone of the endograft extension, either before or after deployment of the endograft. Fluoroscopic guidance and all associated radiological supervision interpretation performed in conjunction with the endovascular graft extension. And again, it could be diagnostic imaging of the aorta prior to the deployment, and again, the angiography to confirm as well. Code 34712 describes a transcatheter delivery of accessory enhanced fixation devices to the endograft, and again, also includes all radiologic supervision and interpretation. However, the next paragraph is important. Vascular access requiring user of closure for devices for large sheaths, like a 12 sheath or larger, or access requiring an open surgical arterial exposure may be separately reported. So again, if we have to put in a larger sheath, they usually have to make an arterial puncture, an arteriotomy, and we can code those separate because this is above and beyond what we normally use. Code 34812 describes the open repair and closure of the femoral artery. So again, where are we? So again, they remind us extensive repair of an artery may also be reported separately. Iliac exposure for device delivery through retroperitoneal incision, open brachial exposure, axillary or subclavian exposure through an infraclavicular or supraclavicular or sternotomy incision during an endovascular aneurysm repair may be separately reported. So again, if we're just going into a vessel and it's not complicated and we're not making an arterial puncture, no extra code. Second, we start doing with arterial punctures, or we're putting the catheter and the deployment devices into another vessel, that's when we may have another code. So it goes on to tell us in the next paragraph, again, balloon angioplasty and or stenting at the sealing zone of an endograft is an integral part of the balloon procedure and not separately reported. However, balloon angiography and or stent deployment of vessels that do not contain the endograft, either before or after the endograft deployment, may be separately reported. So again, we use the balloon to open up areas. So a lot of times, what they're going to do is they're going to open up the area and then they're going to put the stent in. So again, that balloon deployment is part of the code. And again, it reminds us that other interventional procedures performed at the time of the endovascular abdominal aortic aneurysm repair may be additionally reported. Again, as long as it's outside the endograft treatment zone. Okay, so what we're looking for there is, again, we are looking for exactly where are we doing this procedure and what are we doing to it. And again, this is a whole new set of codes for this year and some revised codes. So keep in mind, this is new and you should make sure that you've read all through your guidelines to make sure that you understand what codes go with what. The next set of codes is going a little bit further down. We're still dealing with the infrarenal aorta, but we're also dealing with the viscera. So again, the upper abdominal aorta contains the celiac, superior mesenteric, and renal arteries are termed the visceral aorta. For reporting purposes, the thoracic aorta extends from the aortic valve to the aortic segment just proximal to the celiac artery. Because again, we have to remember that our aorta goes through the diaphragm to come down to the rest of the body. So the celiac artery is where the thoracic aorta ends and where the abdominal aorta begins. Now we've code 34839 is just to report the physician planning and sizing for a patient-specific fenestrated visceral aortic endograft. This planning includes the review of high-resolution cross-sectional imaging and utilization of 3D software for iterative models of the aorta and devices in multiplanar views and centerline flow analysis. Code 34839 may only be reported when, oops, sorry, I cut that off, when the physician spends a minimum of 90 total minutes performing the patient-specific fenestrated endograph. Oh, here it is. Sorry, it is up here. So this code is just for the physician planning. So this is the physician looking through the medical record, looking at the imaging and deciding the shape and size that that specific patient will need for their endograph. But again, it tells us 90 minutes total. They have to hit the 90 minutes to code for this code. Now, these following codes, 34841, 2, 3, 4, 5, 6, 7, and 8, are used to report placement of a fenestrated endovascular graft in the visceral aorta, either alone or in combination with the infrarenal aorta for aneurysm, pseudoaneurysm, dissection, penetrating ulcer, intrarenal hematoma, or traumatic disruption. The fenestrated main body endoprosthesis is deployed within the visceral aorta. Fenestrations within the fabric allow for selective catheterization of the visceral and renal arteries and subsequent placement of the endoprostheses, like bare metal or covered stent, to maintain flow of the visceral artery. Patient variation in the location and relative orientation of the renal and visceral artery origins requires use of patient-specific fenestrated endograft for endovascular repair that preserves flow in his essential visceral arteries and allows proximal seal for fixation to be achieved above the renal level as well as the distal aorta or iliac vessels. So what are they saying here? What they're saying is, again, fenestration. Fenestration is to open. So we are opening an area. So again, we're talking about fenestration within the fabric. There's openings within the fabric, just like the other stents that we were talking about earlier. Now, these codes, 3, 4, 8, 4, 1, 2, 3, and 4, describe repair using proximal endoprosthesis. Remember, proximal close to attachment that span from the visceral aorta component to 1, 2, 3, or 4 visceral artery origins, and distal extent limited to the infrarenal artery. These devices do not extend into the common iliac arteries. And why? Because we now have a whole new set of codes for the iliac artery. So this is just dealing with the visceral aorta and those branches. Codes 3, 4, 8, 4, 5, 6, and 7 are used to report deployment of fenestrated endograft that spans the visceral aorta, again, 1, 2, 3, or 4, visceral artery origins through the infrarenal into the common iliac arteries. So again, what is included in your codes? Where are we going to deploy this device? It then goes on to tell us that codes 34841 through 34844 and 34845 through 34848 define the total number of visceral and or renal arteries that require placement of the endoprostheses. Okay, so again, we need to know how many arteries are we going into. And then they remind us, introduction of guide wires and catheters in the aorta and visceral and or renal arteries is included in the work. So again, getting to the site is included in the work. Also, fluoroscopic guidance. So okay, hold on, let's go back up. Balloon angioplasty is included. Fluoroscopic guidance with radiological supervision and interpretation is also included. Now some revised guidelines. Exposure of the access vessels 34713, 4, 5, 6, 7, 3, 4, 13, 14, 15, 16, 3, 4, 8, 1, 2, 3, 4, 8, 2, 0, 3, 4, 8, 3, 3, and 3, 4 may be reported separately when we're exposing the access vessel. Now, if we have to do extensive repair of the artery, then that can be reported separately. So again, we have to be careful. Now, they also tell us for concomitant endovascular treatment of the descending thoracic aorta and sending us back to another set of codes. So again, it's telling us, hey, sometimes we're doing multiple procedures at the same time, and you may see issues with the thoracic aorta or the iliac arteries that come from other subsections and categories within CPT. Now, we talked about bypass grafts in the first one, and one of the things that we talked about is what is included. So as it tells us, procurement of the saphenous vein graft is included in the description for work for 35501 to 35587 and should not be reported as a separate service or co-surgery. So if we are doing a coronary artery bypass graft and we use a saphenous vein, we just code for the graft. However, if we can't use a saphenous vein for one reason or another, maybe we've already used it, maybe it's not a viable option, and then we go and we get another vein, then we have to code it, and we need to know where that vein is coming from. And again, we're going to code it from where that vein is coming from. So is it coming from the common carotid ipsilateral internal carotid? Is it coming from the splenorenal, the aortic iliac? Where is it coming from? Okay. We also have composite grafts, as it tells us. Codes 35682 to 35683 are used to report harvest and anastomosis of multiple vein segments from distant sites for use as arterial bypass graft conduits. These codes are intended for use when 2 or more vein segments are harvested from a limb other than undergoing bypass. So again, these are very specific, and they'd have to tell us that they are composite grafts. Again, we also have adjuvant techniques. These may be required at the time of bypass to create improved patency of the lower extremity autogenous or synthetic bypass grafts. So these are the kind of synthetic ones. We'll see like vein patch or cuff, things like that. And then we come to the arteries. So we have a little set of guidelines that tells us codes 35879 to 35881 describe an open revision of a graft-threatening stenosis of lower extremity arterial bypass grafts previously constructed with autogenous vein conduit using a patch angioplasty or segmental vein interposition technique. So this is when we have to do a revision of a previous removal of a vein, and we basically have to do a reconnection to it. For thrombectomy with revision of any non-coronary arterial or venous graft, including those of lower extremities other than hemodialysis graft or fistula, use 35876. For direct repair other than fistula for lower extremity blood vessels with or without patch angioplasty, use 35226. And for repair other than fistula of lower extremity blood vessels, use vein graft 35256. So again, we need to know from the provider what they are doing, where they are grabbing their arteries or veins from. Okay, so now we get to vascular injections. So again, vascular injections, there's multitudes of different vascular injections that they can give. They can give injections that can help break up some fatty plaque. They can give injections of different drugs. And so they tell us, listed services for injection procedures include necessary local anesthesia, introduction of needle or catheter, injection of contrast media with or without automatic power injection, and or necessary pre and post-injection care specifically related to the injection procedure. So that's what's all included. They tell us selective vascular catheterization should be coded to include all lesser order selective catheterizations used in the approach. So the description for selective right middle cerebral artery catheterization includes introduction and placement for catheterizations in the right common and internal carotid arteries. Additional second or third order arterial catheterization within the same family of arteries or veins supplied by a first order vessel should be expressed by 36012 and 36218. It also goes additional first order or higher catheterizations in vascular families supplied by a first order vessel should be different from a previously selected and coded family, should be separately coded using the conventions above. So again, for these, so we talked about non-selective catheterizations. So let's talk a little bit about selective catheterizations. So selective catheterizations, what we're doing is we're going from branch to branch to branch to branch. So we have, let's say again, we have a large vessel. It then splits off into another vessel. This splits off into another vessel. And this splits off. Because again, keep in mind, our vessels are like the trunk of a tree. So let me see. This right here, this is the first order. And it's the first order because this is where we started, okay? This is one of the larger of them. Now the first branch becomes the second order. Okay? And then this becomes the third order. Okay, now we also have, in the back of your book, you have your appendix that will help you with this. So if you go to Appendix L, this is the vascular families, and this is how we know. And it tells you at the top, the first order, second order, third order, beyond the third order. So let's go back to the guidelines for a second. So it told us, So it told us that if we are going from the selective right middle cerebral artery, so right middle cerebral artery, let's see. So what we would do is we'd find the right cerebral artery, okay, And then what we would do is we would see where it's going to get to the, so we start with the right common internal carotid arteries. So for instance, if you look on page 798, you would start with the innominate, which is the first order. Then we go with right common carotid, which is the second order. Then we would do internal carotid, so we could get, external carotid, so we get to right middle, middle cerebral artery. So again, we are going from the larger to the smaller. So use Appendix L for your vascular families. It looks a lot worse than it actually is. Now going on, we have diagnostic studies of cervicocerebral arteries. So again, we're dealing with the arteries of the brain. So it tells us 36221 to 36228 describe non-selective and selective arterial placements in diagnostic imaging of the aortic arch, carotid, and vertebral arteries. Codes 36221 to 36226 include the work of accessing the vessel, placement of the catheter, contrast injections, fluoroscopy, radiological supervision, interpretation, and closure of the arteriotomy by pressure and/or application of an arterial closure device. So again, a lot of times they'll use, basically it's a clotting agent that helps it clot and stops the blood flow. It goes on to tell us, codes 36221 to 36228 describe arterial contrast injections with arterial capillary and venous phase imaging when performed. So again, it includes imaging. Now, code 36227 is an add-on code to report unilateral selective catheter placement in diagnostic imaging of the ipsilateral external carotid circulation. It includes all the work of accessing the additional vessels, placement of catheters, contrast injections, fluoroscopy, radiological supervision, and interpretation. So again, what are we doing so we know what we need to code for? Code 36228 is an add-on code used to report unilateral selective arterial catheter placement diagnostic imaging of the initial and each additional intercranial branch of the internal carotid or vertebral arteries. And again, it also includes all the work of getting there, the catheter, the contrast injections, the fluoroscopy, and the supervision and interpretation. 36221 and 36226, again, are built on progressive hierarchies with more intensive services inclusive of less intensive services. This code, inclusive of all the services provided for that vessel, should be reported. So again, let's look at 36221. So 36221, again, it says non-selective catheter placement, thoracic aorta, with angiography of the extracranial carotid, vertebral, and/or intracranial vessels, unilateral or bilateral, and all associated radiological supervision and interpretation, including angiography of the cervicocerebral arch when performed. So 36221, 36222 starts with selective catheter placement. So again, it's a hierarchy. Non-selective is on the bottom, and then selective is on the top for sequencing. So again, the actual selective catheterization, it takes physically more work to do. So it goes on to tell us that 36221 is reported for non-selective catheterization placement of the thoracic aorta and diagnostic imaging of the aortic arch and great vessels. And again, just like it tells you what you can use with and what you can't. So the information that's right here, but the do not reports, is also under the code itself. Don't forget, when you are getting to a code, read the code descriptor fully and always read any notations underneath it. But we do not report 36222, 223, or 224 together for an ipsilateral angiography. Instead, select the code that represents the most comprehensive service using the following hierarchy of complexity, listed in descending order. So it goes 36224, then 36222, 36224, 36223, and then 36222. Now again, it goes on to tell us when a bilateral carotid or vertebral arterial catheterization imaging is performed, add modifier 50 to the codes, because again, these are unilateral codes. We need to tell the insurance company these are bilateral procedures. So then we get to our venipunctures. So our venipunctures, as it tells us, venipuncture needle or catheter for diagnostic study or intravenous therapy, percutaneous. These codes are also used to report the therapy as specified. For collection of specimen from an established catheter, use 36592. For a collection of specimen from a completely implantable venous access device, use 36591. So again, these are, not something that we would normally do. These are not what we would consider to be the routine. So again, it even says not to be used for routine venipunctures, because if you look at code 36415, that's collection of venous blood by venipuncture. 36416, collection of capillary blood specimen. So again, these are specific to trying to get blood from very specific areas for specific diagnostic purposes. Now, as we go through, we get a set of guidelines in between here. And this is because these are revised codes for this year. So we have 36468, 70, and 71 describe injections of a sclerosant for sclerotherapy of telangiectasia and or incompetent veins. So code 36468 may only be reported once per extremity per session, regardless of the number of needle injections performed. So 36468 says injections of sclerosant for spider veins, limb, or trunk. So again, anytime you see the S in parentheses, that can be one or more than one. Okay, so be careful there. Now, ultrasound guidance when performed is not included and may be reported separately. So if we use ultrasound, that is a separate code. Now, code 36465 and 66 describe injections of a non-compound foam sclerosant into an extremity truncal vein, like the greater saphenous or accessory saphenous vein, using ultrasound-guided compression of the junction of the central vein, saphenous femoral junction or saphenopopliteal junction. The limit to the dispersion of the injected. So what they do is they basically kind of close off the vessel after they have injected in this foam, so it doesn't go all over. It stays in that vessel so that it can work its magic by trying to break down the particles that are inside that vessel. It goes on to tell us compounding is a practice in which a qualified healthcare professional combines mixes or alters ingredients of drugs to create a medication tailored to the needs of an individual patient. So again, they can compound these themselves. You can see right here, injections of sclerosant for spider veins, limb, or trunk. It then goes on to tell us, as we go to the next page, that the codes 36473, 4, 5, 6, 7, 8, 9, 34682, and 3 describe endovascular ablation therapy of incompetent extremity veins, including all necessary imaging, guidance, and monitoring. Sclerosant injections of vein by needle or mini catheter followed by a compression technique is not endovascular ablation therapy. Codes 36473, 4, 36482, and 83 can be performed under local anesthesia without the need for tumescence, which is perisaphenous anesthesia. So again, they go under local anesthesia so they can't feel it, but they are not knocked out. Code 36473 and 4 involve the concomitant use of intraluminal devices that mechanically disrupts or abrades the venomous intima and infusion of a physician-specified medication in the target vein. So they go in, they can scrape an area if they'd like to, and then they infuse that vein with the compound that they've made. 36482 and 83 involve positioning the intravenous catheter the length of an incompetent vein remote from the percutaneous access site with subsequent delivery of a chemical adhesive to ablate the incompetent vein. This often includes ultrasound compression of the outflow vein to limit the dispersion of the injected solution. So again, this is the one where we do not want it to get out. So a lot of times we use imaging to make sure it has not moved out of place. And we have to remember, it's not just the injections. We also have things like codes 36475, 36476, which involves advancing radiofrequency devices the length of the incompetent vein with subsequent delivery of radiofrequency energy to ablate the incompetent vein. So again, we're doing a procedure inside the vein, but using radiofrequency. We also have codes 36478 and 79, which involve advanced laser devices. And this time, again, we're doing thermal energy to ablate the vein. So we also have, we have to remember that for subsequent veins, we treat the same extremity. They may be only reported once. So even if we're doing 3 veins in the arm, we can only code the arm once. And we also have to remember, when performing the office setting, all required supplies and equipment are included in these codes. Okay, so anything that they're using to be able to do this is all included in these codes. Then we get to the central venous access procedure. So central venous access procedures are used when we need to be able to get drugs and other therapies into the body very, very quickly, and also be able to get blood out of the body. So first, we're going to look at the pictures of these. So these are the catheters. So what happens is that this part of the catheter is outside the body, and the rest is inside, and it has to terminate or end in very specific places, and our guidelines tell us that. We can have 1 catheter sticking out, we can have 2 catheters sticking out, or this is what we consider a port. This is put in a subcutaneous area underneath the fatty layer that's directly connected to a vein as well. So our guidelines tell us to qualify as a central venous access device or catheter, the tip of the device must terminate, so must end, in the subclavian, brachiocephalic, which is known as the innominate, or iliac veins, the superior or inferior vena cava, or the right atrium. Okay, so that's where they must end to be a central venous access procedure. The venous access device may be either centrally inserted in the jugular, subclavian, femoral, or inferior vena cava catheter entry sites, or peripherally inserted basilic or cephalic vein. The device may be accessed using either via the exposed catheter external to the skin, via subcutaneous port, or via subcutaneous pump. So we use these for a couple of main reasons. First one's for chemotherapy. The second is for people that need constant infusions, or they need to have their blood tested on a consistent basis. So this might be done for someone who, let's say, needs an infusion every single week. So that way we're not poking and prodding them all the time. But again, this could also be used for someone that has an acute infection. So we need to be able to, again, get drugs into their system very quickly. So this can be done as a long-term or as a short-term scenario. So we have 5 parts of this. So we need to know what we're doing. Okay, are we inserting it, which is the placement of the catheter through a newly established venous access? Are we repairing it, which is fixing the device without a replacement of the catheter, port, or pump? A partial replacement of only the catheter component associated with the port or pump, but not the entire device, or a complete replacement, which is a complete exchange. And then the last one is the removal. Okay, so we need to know which one of these 5 we're doing. There is no coding distinction between venous access achieved percutaneously versus by cut down or based on catheter size. For repair, partial replacement, complete replacement, or removal of both catheters of multiple catheter devices with or without subcutaneous ports or pumps, use the appropriate code describing the service with a frequency of 2. So if they have 2 of these, okay, so it's 2 separate access sites, then we can use the same code times by 2, okay, which equals out to the days or units. Okay, so again, here's the pictures of them. One of the big things we need to know is age, because as you'll see, we have a table. This table is on page 253, and again, you'll notice this is what we need to know. Okay, are we inserting, repairing, partial replacement, complete replacement, removal, or removal of obstructed material of device, and repositioning of catheter? So for inserting, is it catheter or device? Again, this is what we need to know. Is it non-tunneled, tunneled, centrally tunneled, tunneled with port, tunneled with pump, peripheral, and then age? Some of them are by age, some are any age. So again, we need to know exactly what we're doing. Out of the 5 possibilities, which of the 5 are we doing? And then we need to know, again, what type, is it tunneled, non-tunneled, etc., and their age. Again, if you like this table, use it. If you don't like the table, you don't have to use it. You can always go back and just use the alphabetic index. The next section is the dialysis circuit. The dialysis circuit, the big thing here is, again, to remember that what we're doing in dialysis is we are removing blood from the body. We are putting it in a machine that spins it, that cleans it, that reoxygenates it, and places it back in the body for people who do not have proper kidney function. This is dealing with making a dialysis circuit, which we can do by using a graft, we can use by using a vein, we can use a device. And so, when we're talking about the dialysis circuit, is where are we removing the blood from during dialysis and where are we putting it back in? How is that circuit running? Okay, so the arterial venous dialysis circuit is designed for easy and repetitive access to perform hemodialysis. It begins at the arterial anastomosis and ends at the right atrium. The circuit may be created using either an arterial venous anastomosis, known as an arteriovenous fistula, AVF, or a prosthetic graft placed between an artery and vein, known as an arteriovenous graft, or AVG. The dialysis circuit is comprised of 2 segments termed 1, peripheral dialysis segment, and 2, central dialysis segment. So, peripheral dialysis segment begins at the arterial anastomosis and extends to the central dialysis segment. In the upper extremity, the peripheral dialysis segment extends through the axillary vein or entire cephalic vein in the case of cephalic venous outflow. In the lower extremities, the peripheral dialysis segment extends through the common femoral vein, and the peripheral dialysis segment includes the historic perianastomotic region. The central dialysis segment includes, again, all draining veins central to the peripheral dialysis segment. So again, in the upper extremity, the central dialysis segment includes veins central to the axillary and cephalic veins, including subclavian and innominate through the superior vena cava. In the lower extremities, the central dialysis segment includes veins central to the common femoral vein, including external iliac and common iliac veins through the inferior vena cava. So again, you can always come back to these definitions when you need more information. It goes on to let us know. The perianastomotic region is near the arterial anastomosis. It encompasses a short segment of the parent artery, the anastomosis, and a short segment of the distal circuit immediately adjacent to the anastomosis. So that's the reconnection. And any diagnostic study or therapeutic intervention within the dialysis circuit that is performed through direct percutaneous access to the dialysis circuit. So again, the dialysis circuit has already been created in the body for people who are already on dialysis. But this is a lot of times when we're going in and we're placing these and we're making sure that they are functioning properly. So 36901 includes direct access and imaging of the entire dialysis circuit. It can do antegrade or retrograde punctures of the dialysis circuit, are typically used for imaging, and contrast may be injected directly through a needle or through a catheter placed in the dialysis circuit. Okay, so again, it's all inclusive there. It goes on to tell us that, again, we want to look for adequate visualization of the arterial anastomosis or the central veins, or selective catheterization of a venous branch may be required. Because again, we want to make sure this is working properly. It goes on to tell us, for the purposes of reporting dialysis access maintenance services, the arterial inflow to the dialysis circuit is considered a separate vessel. So again, we need to know exactly where we're going so that we know what code we need to use. Again, ultrasound guidance for puncture of the dialysis circuit is not typically performed. It is not included in 36901, 2, 3, 4, 5, or 6. However, in the case of new or failing AVFs, ultrasound may be necessary, and we use 76937 if we need to. Now again, for the purposes of coding interventional procedures in the dialysis circuit, both AVF and AVG, the dialysis circuit is artificially divided into two distinct segments, peripheral dialysis segment and central dialysis segment, which we read of. Code 36901, 2, 3, 4, 5, and 6 are built on progressive hierarchies that have more intensive services, which include less intensive services. We report only one code in this series for services provided in a dialysis circuit. So again, what they tell us, 3691 describes the diagnostic evaluation of the dialysis circuit, and this service is included in the services described by 901, 2, 3, 4, 5, and 6. Now, all catheterizations required to perform diagnostic fistulography are included, and all catheterization required to perform additional interventional services are also included. It also includes all angiography, fluoroscopic guidance, road mapping, supervision, and interpretation. Okay. It also says closure of the puncture by any method is included in this service. So that means 36902 includes all of that plus a transluminal balloon angioplasty in the peripheral segment of the dialysis circuit. So again, now we're adding one more part. We're going into more vessels. 36904, again, we're doing a percutaneous transluminal mechanical thrombectomy and or infusion for thrombolysis in the dialysis circuit. Again, it includes everything in 36901 plus, again, the mechanical thrombectomy and infusions. 36907 and 8, again, describe procedures similar through punctures of the dialysis circuit. Similar procedures performed from different access sizes like the common femoral vein may be used with these codes 37248, 29, 37238, and 39, because code 36907 is an add-on code that we use as an adjunct. So again, this is always added on to another procedure. Code 36908, again, another add-on code that we use, and again, we can use this add-on code with 36901, 2, 3, 4, 5, and 6. 36909 is also an add-on code. Again, this time it's used to report the endovascular embolization or occlusion of the main vessels or side branches arising or emptying into the dialysis circuit. So again, we need to be careful. What are we doing? How many branches are we going into? Okay, I'm going to stop it here. I know we only have a little bit left, but I'm going to break this into 3 sections. So we will pick up with transcatheter procedures in CPT Part 3.